This is the No Stroke Podcast with your co-hosts David Dancero and Michael Garrow, helping you to support and thrive in life after stroke. Their podcast is designed for educational and community support purposes only and should not replace medical treatment and guidance of your own health professional team.
Welcome, everyone, to the No Stroke Podcast. We are on our 30th episode here. If you want to go into the nitty gritty, it's season 4, episode 5, but I think we're going to make the call here, Mike, that we're going to go straight from here. This point forward, just going to count them out, right? This 30 is a big one. So was 30 a big one?
31, my college number,
Okay.
So that's going to be another special one.
All right. So we're going to get some of your teammates on for that one, maybe?
I mean, we're gonna have some Irish folks on the line, so that's getting close.
Indeed, we are. That's right. Yeah, that's right. Okay, we'll work with that. So perfect. It's been still a hot stretch, right? Our last episode we talked about precautions and heat stroke, heat exhaustion. And on the Northeast here, at least we're still in the thick of it, right? You hanging in there, okay?
Yeah, you see, I had to change rooms. I don't have air conditioning. I don't have air conditioning in the office, so I had to move into the bedroom for the intro to this.
If I see you starting to melt down, we'll pause, okay?
No, it's nice and air conditioned.
It is.
Yeah, we have air conditioner in the bedroom here, so it's
all right.
That's why I made the move.
Yeah,
it's the West, once it gets to the afternoon, that's when the sun starts hitting the windows, and it's just it turns into a sauna.
Yeah, absolutely. So let's dive into it. We have a great episode. But in addition to the heat still being in the news, let's talk about maybe a few things that came up on alerts for in the news as far as stroke. Okay.
Yeah, you want to lead us off?
Yeah. There's one that's kind of, sometimes when you hear headlines, you're like, oh, what do they mean by that? But there was one that came a sleep stroke study that talked about. The study headline was frequent napping can lead to high blood pressure and stroke. And I'll dive into the details there in a second. But are you a power napper? Because this if you saw this might have threw you off a little bit in terms of, what your impressions were on that.
I am a power napper, that.
Okay.
I'm curious to learn more. I always heard napping was good. I had a lot of professional athletes. They live by the nap.
Yeah.
So let's hear the science.
Yeah. So they probably should have put this in the sub headline, but it's not as exciting, because they're always looking, I think, for something to make the headline. But they said basically the nap itself is not the harmful part, but when they dive into the data, it's the potential that if someone needs to nap all the time and nap frequently, that they might not be getting restful sleep at night when all of the beneficial things, as science is starting to talk about, and we're going to be talking wearables related later, but there's a lot of products that, the Oura Ring, the Apple Watch now, the Fitbits, different models of different products are really trying to dive into the science of sleep. But what they mentioned was that that need for frequent naps during the day is probably a sign that that your sleep quality, that you might be getting poor sleep, and with that it can come an increased risk of hypertension and stroke. And the numbers, again, this is reported by the American Heart and Stroke Association, and they said when compared to people who reported taking a nap, people who often took naps had a 12% higher chance of developing high blood pressure and 24% higher chance of stroke. That's kind of significant. I don't know what the N is on that, Mike. I don't know how many people in the study. I didn't find that information, but I think that it does start to kind of make you think about the importance of restful sleep, and kind of getting that 7 to 8 hours consistent. And there's plenty of tips for that as well about how to shut things down and quiet your brain. So
that makes sense.
So anything on your end, or any other comments there on that particular study?
I used to get 7 to 8 hours, and then I moved in with Megan, who had a cat, and they're nocturnal and they walk on you in the middle of the night. So anybody with cats, you might be, the notorious nappers in that bucket.
Okay.
Yeah. I do my best. It does make sense. Obviously all the research does show, proper rest, but sets you up for that next day. And, when you think of hypertension, there's a lot of leading factors that result back to inadequate sleep patterns. So yeah, I'd be interested to, kind of dive in a little further and see that. There's always something new that's coming out in the stroke space, right?
Yep.
You eat white grapes first, whatever grape, you have a higher risk. Like it's always something.
Yeah. And nutrition in particular, nutrition science is those headlines make me laugh. With that being my background, I'm always like, oh, please don't make that the second thing you report on the nightly news, because it's just ridiculous. But slow news.
It's a little much.
Yeah.
For me, so in kind of the guests that we're bringing on today, we're going to be speaking to some work that was done in kind of the AI machine learning space, and kind of tied in with wearables to support really tracking rehab patterns, right? And being able to bring that into the rehab setting. But to kind of keep in the theme of AI and machine learning, a company that I know you and I, David, we've talked about, and that's been in this space really, in like, when you think about even going back, a decade ago, probably at this point, of companies that first made a real entry into the healthcare AI space, is a company called Viz AI, right? So what Viz AI do, they've built a machine learning algorithm that interprets CT scans, and for when a patient goes in, and that's the first kind of usual sign for if someone is suspected to have a stroke, is to get that CT scan, see if there's a block, a hemorrhage, whatever type of stroke that there might be happening. What Viz AI have done is created a platform which, again, with their machine learning technology, goes in and now accurately predicts at a faster rate than a doctor being able to look at that, who might be having and it's primarily for ischemic strokes, actually. So one part of this is that they just released a study that now they're able, and actually got FDA clearance, that they're able to accurately predict hemorrhagic stroke, so a bleed in the brain. But what's interesting is they recently formed a partnership with a company called Hyperfine. So Hyperfine is this kind of mobile CT scan that is able to go right to the bedside. So Viz AI and Hyperfine have kind of combined in, so it'll be Viz AI's deep learning and machine learning technology within Hyperfine's unit, that it'll speed up the access for patients to get these scans, right? So instead of having to take a patient from the ER up to the MRI scan, wherever that might be in a hospital, they'll have this mobile, like, so if it's suspected a stroke patient's coming into through an ambulance, my understanding of how this would work would be that the doctors would have the scan ready to go as soon as that patient enters the ER, and able to quickly make that diagnosis. So interesting partnership. I'd like to kind of have these guys on in the future to discuss their technology and really the evolution, because they've been around. Like I said, they were one of the first companies to really make an impact in the AI space in healthcare. So interesting to kind of see their growth. They're in a lot of the leading stroke centers throughout the US, and I'm sure certainly abroad as well. So that I kind of pulled that away. I thought it themed nicely to the conversation today that we'll be having with Heidi. And one other shout out, I saw UConn Health Center. So a couple of our previous guests was on as a as a stroke care nurse from Yukon Health in Connecticut. They just won high honors for kind of stroke care through the U.S. News and World Report. So nice little shout out to them. I know you did a talk with them recently, so yeah, nice to see them get that kudos.
Oh, that's great. And good pickup on VisiAI too. I remember them early on, and I missed that one. So let's get both those in the news in our show notes for anyone who wants to dive in and learn more too. But I'd love to, potentially get that as maybe a full interview. So
yeah, I mean, we tend to kind of focus obviously in the rehab space, and a lot of our discussions and project is kind of focused on that acute to long-term chronic stage. But I think with the work that they're doing is so important. It obviously at that stage impacts what that rehab process is like,
everything else, right?
So yeah, it is fascinating work that they're doing. So yeah, we would love to have an episode dedicated to that.
Super. So that leads us to our today's guest. Do you want to give a little background to Heidi before we bring her in?
Yeah, absolutely. So we discussed Heidi's work in it's probably 3 episodes ago.
Yeah.
So it's the PrimSeq tool, which is trying to define an algorithm and technology that can interpret rehabilitation patterns in a clinical setting using wearable sensors. So yeah, it's a really interesting episode. Heidi will kind of bring us through the origins of what kind of sparked this research, their why, and some of the results, and what's coming out of her personal research and that of the facility she works with. So yeah, just a bit of a bio. So Heidi Schambra is our guest today. She is an associate professor of neurology and rehabilitation medicine and director of the epidemiology director and research at the Mobilis Lab. So the Mobilis Lab is out of NYU Langone, which is obviously in New York City. Dr. Schambra received her undergrad in neuroscience from Brown University, and then got her MD out of Emory University. She completed her training in neurology at Harvard Partners and the Neuro Rehabilitation Center at Burke Rehabilitation Hospital. She also completed a postdoctoral fellowship in motor learning and non-invasive brain stimulation at the Burke Rehabilitation Hospital. And when she was at the facility at Columbia University until about 2016. And then she moved to NYU Langone. And yeah, I think we're going to learn a couple fun facts about her as well, possibly about taxonomying clouds, which is pretty interesting. And yeah, as a fellow New York resident, she likes to spin around in a New York City bike. So it was just a really fun conversation with her. I think you and I kind of going into it, one of our things was, all right, what's this mean, for people, and obviously for stroke patients, but folks like yourself in a clinical setting. And I think we covered a lot of that.
Yeah.
What were your thoughts?
No, let's, I loved her AI and training algorithm and the comparison to sniffing dogs. So I think, it was a really great way to make the explanation for folks who you hear AI all the time, and you kind of think that it's going to be something to be afraid of. So I really like the way she explained it and how it can fit in. The human element absolutely has to be there, and it's just only to make clinicians and interpretation of data more precise. So let's bring her in. I mean, I can't wait to share this episode with folks. So
let's do it. Here we go. Hi, Heidi. Welcome to the No Stroke podcast. Pleasure to have you here.
Thank you so much. Yeah, thanks for inviting me.
Absolutely. You you've been a busy woman lately. We've seen you in the news a little bit for those who kind of follow the neurologist space. And, it's really exciting to have you on here. A lot of our work is all, focused around this rehab space. We've talked about wearables, we've talked about, kind of really driving this next phase of innovation into the stroke care pathway. So really excited to dive into the work you're doing. But before that, let's give a bit of background to our listeners, where you are, where you're located today, where you've come from, and kind of how you've gotten to your position with NYU Langone.
Yeah, great. Thank you. Yeah, and thank you again for this amazing podcast. It's a wonderful asset for our patients, our stroke patients and individuals with stroke who are sort of working through their consequences. So thank you for bringing the new technologies to this group of folks. So I'm at NYU Langone. This is in New York City proper in Midtown Manhattan. And I've been here for, now 6 years, previously at Columbia, just up the road. And before that, I've, have trained all over the East Coast, I would say. So I'm a trained neurologist. I did my residency at Mass General and Brigham and Women's in Boston, and then did a postdoc at the NIH, and did some additional fellowship training at Columbia and Burke Rehab Hospital in White Plains. And then, have developed a clinical research lab here. So that's been my academic path. I'm a North Carolinian by birth. Barbecue can only be done right down there, but that's sort of my background.
Very nice. What part of North Carolina?
Chapel Hill, North Carolina.
Go
Tar Heels,
I wasn't. Right. So before we, get into some of the serious stuff, we like to ask, do you have a fun fact for us that we could?
Yeah, I had so many fun facts, but I think one of the things I really love to do and actually inspired the origins of this work is to learn the taxa of clouds, the taxonomy of clouds. So, there's just this rich sort of history of trying to identify cloud types based on their phenotype, but also their elevations, and of course, they're used for predictive qualities, but it's just they're lovely to watch. It's really fun to learn the Latin scientific names for them and the variants and so forth, and to recognize that there are patterns in chaos and sort of wildness out there, and but there's sort of regularity in nature and regularity in how we move, and so that was sort of a launch point for me. So completely recommend, if you haven't already, to get the Cloud Spotter's Guide. It's a hilarious book. It's very entertaining, but you will learn a lot too. And and you can see where I started thinking about taxonomies of entities from that.
So we could find you the weekends in Central Park, looking up at the clouds. And
yeah, most of the times I have a window right there, and I have a little sliver of sky that I try to look and see what's floating by when I'm trying to write great answer papers and think big thoughts. I can always lock back to my clouds.
That is interesting. I'm writing that down because I have a cool app for stars, and I think it's the greatest thing to be able to identify the constellations. So all that tech stuff. So on the tech side, Heidi, interesting. When I was reading some information about you, I get very excited when I see anyone's in the wearable and talking tech for stroke rehab. Can you tell us a little bit about your interest there? Maybe what potentially sparked it as a stroke specialist, and how do you the term that the specific tool you're working on, PrimSeq, is that something you can speak to for us?
Yeah, absolutely. So it's funny how I arrived here, because I didn't necessarily set out to do methods development research. The big story I think that's happening in neuro recovery and neuro rehabilitation of stroke, and particularly in the motor systems and in the arms, which is sort of the area I study, is that there are some critical ingredients that, there are a lot of reasons why people recover after a stroke, and there's some innate sort of plasticity that gets kicked into action because of the stroke event itself. But there's also, there are things we can do with therapy to really power up that type of intervention. So it really engage the physical training that's delivered by occupational therapy or physical therapy. And so one of the key sort of ingredients that's emerged certainly from the basic literature and the preclinical research in rodent models and monkey models of stroke is that, you know, repetition really matters, particularly early on after stroke. And so the number of movements that an animal is making really will drive whether an animal recovers in sort of a meaningful way versus they don't recover. So there's a little bit of a bump just by that inherent, we call endogenous plasticity that occurs after stroke, but it's not really enough to kind of help people or help animals in this case recover fully. So the repetition is a key component. That dose or that intensity of training is a real key component. And we know this from like just basic motor learning principles, right? Like you need to practice a ton in order to get skilled at something. You know, you don't just do it once and you improve. And so that's no different really from the post-stroke brain. So so that's become a key thing. And, you know, obviously the question we have is, you know, well, how much do we have to give in order to get that sort of traction, to get the brain sort of engaged and really rewiring and reorganizing in a way that's behaviorally meaningful. And so, you know, when looking around at that, you know, as a neurologist who's really interested in rehabilitating and sort of pushing plasticity and recovery, you know, like I couldn't get a number from anything. And the best we have is like, you know, some numbers that are estimated from these rodent models that are, you know, like sort of reaching to pellet, eating, you know, and that's it. But, you know, obviously we don't do that in rehab. You know, we don't reach to pellets of food and feed ourselves and that's it. You know, this is all very ADL practiced and, you know, based, and, you know, we're looking to try to improve function and daily activities and, you know, gain independence through, you know, self-care. So trying to map what was happening in rodent world to what was happening in a rehab setting, it was too disparate. So, you know, I couldn't sort of say like, okay, well, we need to do sort of this amount of reaches of, you know, toothbrushing or, you know, washing your face or something like that. You know, like, so we have, like, in my mind, I have to break it down to something more almost algorithmic. So I need to know sort of a dose or an intensity that's, you know, can be practiced and trained. And reliably create a sort of a recovery effect, right? So that's where I was about 6 or 7 years ago, just feeling like, I just need to know what to do with these patients, you know, to help them recover better. You know, like what can I give early on that will really make a difference for them? And I couldn't work with, you know, like I wasn't able to say anything to, you know, the therapist team that I, you know, was working with, and it felt very like, you know, I didn't have any objective information to tell them. So that got me to this project, which is trying to find a way to break down those rehab activities into measurable units. We call them primitives. Primitives are just basic sort of building blocks of motion that are functional. So these are like a reach or a transport or a reposition or a stabilization. And essentially what can happen is those will be sort of strung together as you complete an ADL, an activity of daily living. And so, but the point is with that, you can break an ADL back down into those fundamental units. And those are things you can actually count. And you can say, this is what I want to target in order to get better and so forth. And so that's where the tool came in, was this idea of like, well, we need to figure out a way to count these things. First of all, we need to identify what these basic units are. That was some work I did previously, and to reliably say that we can break ADLs down, or functional activities trained in rehab, down into these measurable units. And then we need to find a way to reliably detect them and count them. And so that's the PrimSeq tool, which is essentially a way to take motion data off patients who are undergoing rehab and be able to pull out those primitive elemental motions. That's a lot. So I don't know if I answered your question about the wearables piece of that.
Yes, absolutely. For someone who might not be familiar with the term wearable and the can you describe what that setup would like for someone that you were following during your research? Is it these externally worn sensors? How many of them are there? And,
yeah.
And maybe talk to the accuracy of them that you found in your research.
Yeah, so a big decision point early on in this research, I will get to that question, but the question was, what is the best way to capture motion of people? So one sort of branch point is, cameras, so video cameras like we have here. And, you can, there are lots of approaches now that can decompose and like sort of extract data from just video data. My concern was that in a rehab environment, with people turning away from a camera or someone walking in front, you might get a real loss of data. So I was very attracted to the idea of wearable sensors. And so in this case, I used, or our team used, what are called inertial measurement units, IMUs, which is a combination of accelerometers, so they tell you sort of linear motions, and combined with rotational motions from gyroscopes. And so it's a nice, particularly for the arms that have a lot of rotations and a lot of, you can position your arm in lots of different ways. You want to be able to capture where it's going in space at all times, and accelerometry I don't think really does the trick, just because, if you rotate, it'll totally change your, data that are coming out. So the gyroscopes they do give a lot more sort of refined and detailed data, I would say. So the wearable sensors, we had 9 IMUs on the upper body. So we had 3 on each arm, and then we had 3 down the back, down to the pelvis. And the great thing about this was an off the shelf commercial system, Noraxon, that we used to pull off the data. So it's not only collecting this acceleration, the linear and angular accelerations, but it's also using a model that's sort of sized to the person, able to recreate some of the joint angles of the upper body. And so with all of that data coming in off people, so we'd get 76 streams of information coming off of per 10 milliseconds off of each of these patients. So it was, it's a wireless system. They're about matchbook size. We put them on with Velcro and with Tegaderm tape, on the dorsum of the hand so that the fingers are free. And they were really well tolerated. They're not there, they're not sort of invisible. You do feel them, but they're light. You can move freely with them, and you can roam around space. You can turn away from people, and you're always collecting data. So that felt like a much more reliable source of continuous data for me.
So once you kind of had this, the concept of how to capture the data, and then you're, pulling it into this machine learning algorithm, what were some of your objectives laid out with kind of how you were going to learn from all this data, and like what was your goal from that?
Yeah, so to build this, you have to, so machine learning is, it's like teaching a toddler how to learn a new motor skill or something, like you want to say, you have to, that's maybe a bad analogy. Let's change it. So I like the thought of it being like, one of those sniffer dogs, that you see at the airport, right? So it's going through a world of sense, but it's been taught to identify, explosives or, drugs or fruit or whatever, right? But back in the day when it was a puppy and it was growing up and learning to identify those things, it was given lots and lots of examples and reinforcement and reward when it got it right, and sort of recognizing when it got it wrong before, it was trained to the point of detectability, able to reliably detect those particular scents in this, sea of scents. So when we go about with machine learning, and when we do any kind of what's called supervised machine learning, you're teaching an algorithm, which is really just a fancy computer program to learn what you want to teach it. So you have to give lots of examples of the thing you want it to identify. So we had, a group of individuals with stroke come in and do a lot of rehab activities for us. We simultaneously recorded them with video, actually in this case, but video and the IMUs, the sensors that are worn on the body. And then we took that video and we watched it. So we, meaning a host of undergraduate trained students and coordinators who were taught how to say, okay, this is how we define, as humans, we define a reach, this is how we define a transport, and here's where we say the start of it is, the end of it is, and so forth. So we as humans are watching this video, we're breaking down those activities into those fundamental units. What that effectively does is it then chunks up that underlying, that 76 dimensional data from the sensors that's associated, that pattern of data that's associated, that motion data that's associated with, say, a reach. And you're handing that off to the algorithm to then say, okay, when you see this sort of pattern of craziness of data, this is going to lock, that's when you need to call it a reach. And this is the pattern that goes along with the transport and so forth. And so you give it thousands of examples of these types of primitives. And over time, it starts to learn the nuances of whatever's in the patterns that it's letting it to make its classification correct. And it learns essentially that relationship between your class, which is our primitive, and the pattern of motion that's associated with it.
Yeah. So how, and like for someone with left arm spasticity, right, whose reach might be at a certain degree versus another survivor who has a greater, reach, how do the kind of algorithm still able to pinpoint those? And
amazingly. So it's a mix. Okay, so I guess the first thing is you have to train the algorithm on who you want to sort of test on down the road, right? It should be totally patients and so forth. But we had mild to moderately impaired patients. And I should say that when the exclusion was having an Ashworth of 4, so if people were contracted, we didn't have them in this initial sort of run. But there could be sort of some significant spasticity. Typically it was around an Ashworth of 2. So that's, anyway, the point is it's people were able to move. If you give enough examples, and why we wanted to train the algorithm not on healthy people but actually on stroke patients just from the outset was, we were assuming that there may be a lot of trunk motion, or there may be a limited, shoulder flexion and arm extension. That's going to be part of that picture of a stroke impaired reach or a stroke impaired transport. And so we gave, again, a lot of examples of these different types of reaches in different places in space by patients with different levels of impairment. And actually for the mild to moderate impaired patients, it did really well in terms of predicting, reaches and transports and identifying them in the new group that it had never seen before. So actually it did really well. In terms of taking that, that algorithm that had been trained previously on mildly and moderately impaired patients and seeing how well it would do in, say, a severely impaired patient, it doesn't do as well because it's never seen a patient reach like that before, right? So you can't sort of assume that it's gonna, been taught French and be able to speak Spanish, So it has its limitations in terms of how well you can generalize to folks who are moving in a different way. And the same thing goes for if you had ataxia, you had some tremulousness or tremor, significant tremor, or other types of movement disorders. It wouldn't necessarily be able to detect things as well. I don't expect it to do that because it had never seen that.
Heidi, I love that example you just gave on training the AI or training building the algorithm using a dog and like the canine percent.
Yeah.
It resonates right now because I have a young lab at home and we're trying to do just that. So, but it's the first time I heard it explained like that, and that's impactful. Because I think there's this thought and a lot of as I try to talk to other PTs about merging technologies and things, they think, well, like a cyborg's going to take over their job or something, and it's not the case. But I think I'm going to have to pass this episode on. I'd like
and it's go ahead. Sorry, finish.
No, go ahead.
No, I was going to say, there is no way we could ever swap in a robot or swap in an AI technology for a therapist. I 100% will be the first person to admit, it is, seeing how, OTs and PTs interact with patients, there is so much more than just dosing and, getting the reps up. There's a whole psychology, motivation, shaping, getting the impairment, addressed and targeted, like so many more ingredients, so to speak, that will help a patient recover than just reps. So my not argument, but my goal will be to support a therapist in saying like, okay, now that we have a device that can measure something, now that we can actually have nailed down, 10 years from now, have nailed down how much people actually need. Let's get to, a means of, reading out how patients are, how well they've done. Are they getting up to this sort of number that we're all trying to hit? Like how can we sort of squeeze it, get more out of this? Like, are we ahead of our goal? Are we behind our, it's the same sort of, that feedback is actually really empowering. And actually there's some interesting work that came out in the PT realm, you guys, up your guys' alley, but Janice Ng, just published a dosing trial with treadmill, like, sorry, not treadmill, but like steps and gait therapy. And, it was a dose escalation trial, and, finding that like having feedback, and first of all, the higher dose was more effective in helping these patients ambulate, achieve a higher level of ambulatory function earlier in their recovery process. But one of, I think, a really interesting takeaway was like having an information for the therapist about the heart rate target, where they were in their zone in terms of how many steps they had accomplished with respect to what they were trying to accomplish. That was not only empowering for a therapist to say like, look, Mr. Jones, you're a little bit behind here. Let's try to get to this. So it was sort of like giving a patient sort of an objective. It was sort of external to a therapist, not being, being hard on the patient, but, actually trying to go and work with the patient to achieve this external goal that would help them. And the patient was really excited because they could see how they're progressing and how much they've done. And, so like just having that information in the rehab space, I think will be incredibly useful for both the therapist and the patient. Like I think the team that is sort of coming at it together, I think will only be very helpful. But
yeah, I guess like what I'm correlating a lot of this to is my past training. So I played basketball at a kind of semi-professional level, right?
Oh, great.
And I spent a lot of time in the gym. I spent a lot of time on my routine, on my follow shots. And I always, whenever I worked out, I had a number, right? I'm going to make 300 shots today.
Right.
To me, because I was paid to play, I had the opportunity to stay in the gym for however long that took, right?
Mm-hmm. Yeah.
And I think the model right now, when we look at stroke rehab, it's really kind of session based, right? So
yeah.
Like, do you see this and is what you're trying to move towards saying more so, hey, insurance companies, we need to reimburse more at the rep level rather than you get 12 sessions every 6 months as a stroke survivor or whatever?
Yeah, it's a great question. Like, what will change the game? I think probably we are all on the same page that what patients and survivors of stroke are getting is not enough. In the sense of it's not long enough. Our lengths of stays are shortening in the acute inpatient rehab units. And there is a period of plasticity that is, maybe a window of opportunity that's about 3 months at most, if not shorter, that we need to engage aggressively. So what we need to show in order to change the insurance sort of construction, I think, is first to show that repetition really does matter. It does actually cause an early effect. It causes a longer sustained effect. Probably I'm sure we need to show some monetary benefit of that, like it's less downstream cost for, either rehab therapy certainly, but also, other medical care and comorbidities. So, I think there needs to be shown like ultimately a financial benefit to investing early and aggressively in training. In terms of what can be accomplished, I don't know if we can stay with the same, the 3 hours of therapy. So I'm thinking like in the acute rehab unit where you have 3 total hours a day, right? So split across 3 domains, PTOT and speech and language pathology. And, so most patients might be getting an hour and a half in one of those domains. And first of all, I think we need to figure out like how much do we need to be doing actually in order to be getting some real traction with recovery, a bigger boost than what patients are already sort of naturally getting. So that work needs to be done, and then I think then you're trying to look at, okay, does our existing structure of maybe 30 minutes up to an hour and a half, can that accommodate the number of repetitions that need to be done in order for a patient to recover? So I think the first thing we need to do is actually figure out what that intensity is in order to see that. And I should say it won't be the same for all levels of impairment. So for a patient who is severely impaired, it's going to be harder potentially for them to get 300 repetitions or 900 repetitions of something, right? So, we may be trying to look at other ways to, augment plasticity in parallel, through brain stimulation type approaches, through medication. It may be something where we need to keep it, we need to spread it out over the course of a day, or we just say, we're never going to get 300, but, for us to get to that sort of level that they will, maximally get, with the degree of injury to the brain, they're going to need this amount. So again, the study is looking at intensity response, that sort of dose response relationship. We'll be stratified, and certainly this is something we want to do, which is to see, okay, within this sort of, if you arrive with this level of impairment at the very beginning, how much can we kind of boost within that for that stratum of person, and so what is that critical amount for that group, for a higher level, for medium level, and so forth. So that is also a piece that needs to be brought into the picture of what people will tolerate and what they're able to do within a period of time.
And I think we're all in agreement. Might get a good analogy using the sport theme. It's reps, 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 right? Not to oversimplify recovery, but it's putting in the time, and it's not, it's not 2 sets of 10. We learned from some of our early research when we were coming back right before everything shut down during the pandemic. We were at the International Stroke Conference, and there were some and the rehab sections that I attended, they really talked about, when they did count the reps in outpatient setting, like it averaged 32. I think it was Steve Kramer or someone else from UCLA. And it's like, we know that just isn't simply enough. And there's a big cost to everyone involved in that stroke survivor's recovery in terms of getting there for that dose of 32 reps. So with that known, you're working on the other end, which is, what is that stimulus, or what is that? How do you feel therapists, do you eventually see this as an adjunct to what they're doing in the clinic? Maybe the big thing we heard is, that stroke recovery is moving into home in some shape or form. Do you see your tools being having utility there, and how would that look like for the way home stroke therapy is done now?
Yeah, it's a great question. And, if we stay on this course of discharging patients, well within their window of opportunity, then, we will need to transition to home-based type of, or remote or virtual type of rehab setup. So my ideal for this will be a couple things. So one is, the wearable sensors, it's a big array. So we would like to find ways to kind of streamline that. And you could combine with like a single camera, again, trying to avoid data dropouts and so forth. But there are these data hybridization approaches where, you can get a lot of rich information simultaneously, but may be able to cut down on how you're collecting it. That's a key piece that needs to happen to be able to go home, and even actually to go into a rehab setting. You don't want it to be a clunky setup for a therapist to have to help a patient on. So that's one big piece. The piece of ideally I would like to have this be something where a patient can wear the sensor array or have a camera associated with it, and essentially just plug in and do their repetitions or even do their day-to-day activities. You know, while people are moving around, they're doing something functional, and I think there's a way to potentially reinforce that. So you can gamify that system certainly and make it like, you know, how you have your pedometer, your Fitbit, you're sort of seeing how many steps you got in for the day. It's the same sort of readout that I would like, you know, the number of primitives you've done during the day, or, you know, and trying to set goals in that way. So not only integrating use and sort of promoting real world use of that impaired side, but also, you know, could be gamifying it with, you know, like practice sessions and sort of working with, you know, different video game type platforms where patients can really kind of get into sort of those motions. But my sort of gut sense is that, like, the more we can get people to practice, to train in situ, like to be training in the home and in working with those objects that they work with. Like, I think the virtual space idea, while it's compelling and exciting, it's you know, there's nothing like the real thing, right? So you really like to be able to sort of reinforce that sort of utility in the home space. And of course, then taking that information and communicating that back to therapists, and then also being able to give that feedback during a remote session, I think is also a really key piece. So, you know, it's a data collection tool. It's meant to, or it's a counting tool. It's at its simplest, right? It's a fancy kind of back end, but the idea is just to count this stuff up. It's not brilliant, like in terms of the concept, you know. I just want to have some way to like track what a patient's doing, you know, so that we can then modify it or intervene or like sort of reinforce it, you know, and let patients know how they're doing and tell them they're, you know, making good strides, you know, like it's pretty simple. So we've had a fancy way to try to hit this, but I think it's important information.
Yeah, and soon to be in the metaverse, probably, right?
In the metaverse with
that'll be the next step.
with going into some wonderful rehab setting in on Quito, and you know, and rehabbing there, that would be amazing. Yeah,
So,
it actually does a pretty good job replicating. I don't know if you.
Yeah.
It's got a good avatar.
Interesting. Yeah. I mean, I think we could have another session on metaverse, but it is, you know, I think, you know, we looked, or some of my early research was in virtual reality, and you know, it's being able to train that cognitive sense as well. Like, you know, you're in a plush PT studio is way different than, you know, stepping onto a bus for the first time, or you know, going down a cobblestone street. So it's going to be interesting to kind of see where that space goes. But let's talk a little bit about, you know, where this research is kind of originated from, and some of the work that you're doing at, is it Mobilis Lab?
The Mobilis Lab, yeah.
Mobilis Lab. So can you talk to kind of what, you know, that organization is structured from, and kind of your mission, and obviously, you know, some of the other research that you might have in the pipeline?
Yeah, so, you know, my lab, we're a small but mighty crowd. We are a group here at NYU, and we, you know, my mission is sort of twofold. It's, you know, to understand mechanistically how the brain is recovering. Brainers, I would say, you know, neural systems are recovering after stroke. So at the pathway level, at the, you know, cellular level if possible, but really we study pathways. And using that information to develop new methods or new technologies or new therapeutics in sort of a rationally designed manner to really boost recovery. And so, you know, we're very interested in neuroplasticity, sort of how it innately or endogenously occurs after stroke, with a goal always of, you know, with that information, you know, what can we do in terms of our interventions to really target that and boost it and increase it, that plasticity in particular. So along those lines, you know, we have this work that, you know, ultimately is meant to, it was a method in order to support the work that would be, you know, like, we need to build a targeted approach to dosing, you know, appropriate. We need to be able to measure and quantitate and do those dose response studies. So in the absence of any other sort of tool out there, you know, sort of step back a notch and say, okay, well, let's develop that tool in order to support this type of research. And, you know, of course, researched by other people in the field. So that's the quantitative side of things. But, you know, ultimately leading, I mean, the end game is always to do these dosing studies. in a very objective, measured way, just so we can start to get a handle on, at least at the repetition level, what do patients need in order to get better if we give it early enough. So that's one major line of work. So from a mechanistic standpoint, otherwise, I have a line of work looking at a different type of pathway than we normally think about for motor recovery after stroke. And so, we, as neurologists, we think about the corticospinal tract, which is a major driver of movement, particularly for the arms and particularly for the hands and fingers. What's becoming sort of more, I think, the field is becoming more aware of in the last, 5-10 years or so, is that there are these other pathways, right? It's not just the corticospinal tract. There are other motor pathways in the brain and in the spinal cord that may help or take over with recovery. So say you knock out the corticospinal tract, there's another pathway called the cortico-reticulospinal tract, or we call it CREST for short. And this is an older school pathway. It's a primordial type pathway. Actually, a lot of our less evolved relatives use this pathway predominantly for motion or for movement generation. And it's between, essentially the cortex and the brainstem, and then the brainstem out to the spinal cord. And so we're probing that pathway now in a study that's looking at recovering individuals with stroke who are in the first 6 months after stroke, and we're tracking this pathway on the other side of the brain. It descends bilaterally, so it sort of sends a projection to one side and of course to the other side. So if you have a stroke, the thinking is that this pathway may sort of like jazz up and come online to take over some function. And you're dealing with a paretic arm, it's actually, you have an available pathway to help with that. And of course there's good animal work to justify that, and there's been a long history of, oh wow, this other hemisphere actually lights up after you have a stroke and it seems to be really active, and there's been a lot of narrative about, oh, it's a bad thing, but actually this may be the pathway that's sort of coming to help restore some function, coming to assist. And so we're probing that with transcranial magnetic stimulation, trying to listen to the circuitry of that pathway, and then also with some fancy imaging to look at some of the neurostructural changes that are occurring in the gray matter and the white matter tracts. And so stay tuned for those results. Hopefully we'll have those in a couple years. We're in the midst of data collection right now for that. So that's the two big active lines of research. And then we have a third that's coming online, which is looking at vagus nerve stimulation and the mechanism of that. And so stay tuned for that as well.
I feel like we have to have you back on to dive into all that, because I'm getting my most difficult training was the neuroanatomy during and I love hearing it now, because I was very lucky that I didn't get rid of all my neuro
textbooks
notes, because I didn't know, fast forward 6 years out, that I'd have my own stroke and have to figure like really dive into why I'm doing what I'm doing. So thank you for putting that out. And I think that I want to be respectful, Mike. Is it about that time? It's about that time. Heidi, you might not know what this is. We do stream this on YouTube as well. This is our magic wand. We are a low budget production right now, so this is the best that we can do. But Mike, do you want me to hand you the magic wand, or?
We'll pass it in the metaverse.
Okay, there you go. Ask away, Mike.
So, well, first, before I get to the magic wand question, for survivors out there who or caregivers might be interested in learning more about, your specific research, is there any way to guide them?
Yeah, I mean, you can come to my website, and there's a contact on the last page. My website is mobilislab.com. That's my lab's website. You can also, and that's, I don't know if I'll spell it. Mobilis Lab is Mobilis Lab, one word. And you certainly can look me up online or contact me by my email. It's also available online. So happy to talk with you and to talk about our research studies. We do have a registry. We always have new studies that are coming online. And these aren't necessarily folks who have just had a stroke, but may have had stroke, a long time ago. I study the arm, so we really do focus on arm impairments, not so much language or cog or gait abnormalities, but That's, so we would look for that. But you're welcome to contact me. I'd love to have you join us, especially if you're in the tri-state area, then we can, bring you into our area, tri-state New York City area.
Awesome. Yeah, we'll list all that contact info in the show notes for folks. Perfect. So yeah, we tend to wrap up every show with our magic wand question. Yes. So we're handing you the magic wand. And if you were able to use that magic wand to redesign the stroke care pathway, what would that look like?
Yeah, I think, okay, magic wand, I love it. It's, so first things first, once we're out of that acute window in that first week after a stroke, getting an individual into as intense a rehab sort of an environment as possible. Intense meaning like you're training, you're doing that sort of integration with a therapist. You'd have a bespoke team who would stay with you. And that, so there's not a lot of transitions of care, and like you can really work and grow with your therapists. This would be a longer duration, so not just the 2 weeks that are typically given, at least a month, if not longer. So we're really actively engaging with our wonderful clinicians, that robust neuroplasticity that's occurring after strokes at least a month, if not longer. And then really transitioning very, very quickly to a home-based virtual rehab platform where we do have, again, a way to measure how much patients are doing, so that, there's a very clear link to not only them, but also to the therapists, about, what we need to be giving, how they're doing at home, making sure they're integrating into home use, which is another big point of drop-off. So that sort of real-world use. And having a much just tighter relationship, I think, with our patients. It's just too high throughput, and I want to make sure, like, this is a period of time which is so critical, and where I think interventions will really make a tremendous impact, but after 3, 6, 7 months, it's harder to get that same sort of amount of change. It's not impossible, I shouldn't say don't lose hope, but it's harder, and I think we can leverage that, though. But it is something where we have to be a lot more, aggressive and like much more in engaging the brain and engaging a patient during those first months after stroke. So really just a sort of a system where it's much more integrated. It's integrated with a therapist. The therapists and the patients are informed objectively about how things are going and where we should be aiming to go with our patients in terms of training amount. And and then continuing that at home. That will be my magic wand. And then lots of cool neurotech with that, with motion capture and, working with virtual spaces and like all that sort of enriched sort of experience. I think that would be spectacular.
Great answer, Heidi. And we've been at this for close to 30 episodes, Mike, and every time we hear the magic wand, they get better and better. So, and we keep saying we have to do sort of a montage and put them all together because there's this underlying theme that we have to do more, and we have to, so really want to thank you for your time this evening. I'd like to get you hopefully home, hopefully, as this might be the end of your day. So maybe before dark here. So this has been a pleasure. We're going to put all the show the links that you shared in, and we hope to our community follows up and can engage if they're in your area as well. So Mike, take us out. This has been great. It's a pleasure to meet you, Heidi.
Yeah, well said, David, and Heidi, thank you again for your time. Maybe we'll catch each other in Central Park one day.
I would love it. That's great. Looking at clouds, right? Well, thank you, Mike and David, and thank you for this work. I really appreciate it. And I know your listeners and observers do as well. So thank you. And let's keep at it. We're going to make some changes in our field, right? This is important.
Got it. Absolutely. We're committed. Right. Thank you, Heidi.
Okay, good. Thank you. Bye-bye.